Yes, sir. We can hear.
Guys, can you hear me?
Yes, sir. We can hear you. Hello, sir.
Okay, I can hear you. Should be able. Okay, can you hear me?
Yes, sir. We can hear you.
Okay, right. Loud and clear, yes?
Yes,
And
sir.
the screen is on.
Yes, sir.
Huh?
Yes, sir. Screen is on.
Okay, I don't hear you really well. Let me see. Okay, can you just say something again, please? Okay, can you confirm again, please?
Yes, sir.
Okay, brilliant. That's fine. That's perfect. Okay,
Okay.
so I thought I will, I'll keep my video. Oh, good, my connection is. I thought I'll speak to you about a couple of gynecology topics today. So we'll start with endometriosis. Now, a little bit of theory first. So endometrium is the inner lining of histology which you learn. It's a complex, a rather complex tissue, both functionally, physiologically functionally, as well as in anatomical terms. And the basis of endometrial lining workup is that for each menstrual cycle, the endometrium will regenerate from a basal layer. And whenever there's a pregnancy, that would happen in a brand new environment where it will be nourished for the initial parts of the implantation process. Now, to have that happening, and you will remember all this being done some long time ago, the endometrium undergoes 3 phases during the cycle. One where it proliferates and grows and differentiates into the tissue, and a secretory phase where it mainly differentiates and creates an environment where implantation can take place. And if that doesn't happen, then the hormones support drops. The tissue breakdown occurs and it goes back to a basal layer. Now that can happen cyclically on and on and on from menarche to menopause without giving trouble. However, whenever there is endometrial tissue in other places apart from the anatomical endometrial or the inner lining of the uterus, there comes problems, and endometriosis and adenomyosis are both related to these problems. We will leave adenomyosis as a separate topic for a different day, because to understand adenomyosis and treatment, we will leave that for another day and concentrate ourselves on endometriosis. So presence of ectopic endometrial gland and stroma outside of the uterus basically will be endometriosis. Outside of uterine cavity in the uterus will be adenomyosis. Now, how do these patients present? They present with, they could be completely asymptomatic, some of them. However, characteristics of endometriosis include dysmenorrhea, severe deep dyspareunia, and chronic pelvic pain. It's also one of the leading causes of infertility for women. Now, as you remember, dysmenorrhea can be of 2 types. One type is where the primary dysmenorrhea or where there is no pathological cause defined. That is because there is prostaglandin production during the menstrual part of the cycle, and that prostaglandin production also is a cause for pain. Whenever there is a cause for dysmenorrhea, you can call it a secondary dysmenorrhea. That is a definition taken from the fact that anything secondary will mean there will be a primary pathological cause resulting in that symptom. There are various ways one can actually differentiate a primary to secondary dysmenorrhea. When we discussed about menstrual problems and dysmenorrhea, we discussed that characteristically secondary dysmenorrhea will start long before the period and will actually outlast the menstrual period as well. So they with endometriosis, they can present with secondary type of dysmenorrhea and deep dyspareunia, pelvic pain, and infertility. Now, where do we find endometriosis? Technically, if you look at the case reports or reported cases, it has been found everywhere, including the eye, muscles, various lungs, various other parts of the body. So it's not completely confined to pelvis, but most commonly endometriosis presents in the pelvis. So commonest sites for endometriosis include the pouch of Douglas, the anteriorly the vesicouterine pouch, the pelvic peritoneum of the pelvis, fallopian tubes, ovaries, the ligaments, and suspensory ligament of the uterus, and sometimes in as patches in various parts of the abdomen. Now, if you look at endometriosis in terms of diagnosis, the correct or the actual diagnosis requires biopsy or taking a sample from the endometrial, the ectopic endometrial tissue, and looking at it with the microscope to confirm that is indeed endometrial type of tissue. However, when you have a look at the pelvis, especially in laparoscopy, you have various ways of identifying endometriosis. Now, on your left-hand corner here, on your left-hand corner, that's endometriosis patch, that black. Do you see my arrow as well?
Yes, sir, we can see.
Yeah. So that's a patch of endometriosis, and that's starting from the key thing about this type of endometriosis is that they can actually infiltrate into the tissues, and these patches can be either confined to the peritoneum or can infiltrate into tissues. When they infiltrate into the tissues, we call them deep infiltrating endometriosis, or DIE for short. Now here, these patches, these red patches here are also endometriosis. They are not actually infiltrating. However, here, where in this patch, you can see that it not only infiltrates into the tissue, but it also causes fibrosis and resulting in the destruction of the correct anatomy behind this patch. Now, if one were to have the ureter going like that, then that distortion actually can kink the ureter, can lead to blocking of the ureters, and that's a similar structure wherever it is. So these type of endometriosis can cause symptoms fairly unrelated to the pain and present in various ways. Here again is another deep endometriotic patch, where why we call it deep, because it is deeper than the shiny peritoneum, and it has actually started to, it is very active endometriosis, and it has started to collect as a cyst, and that is not the ovary. And here one can see ovarian endometriosis, and that resulted in this woman's ovary being adhered here in the ovarian fossa. Now, if one were to leave it alone, it could have developed into an ovarian cyst, or a lot of obliteration of the pouch of Douglas, and extensive endometriosis leading to deep pain. For example, if the ovary was adhered here, if one were to have, when one is having intercourse, especially when there's deep thrusting, or secondary dyspareunia, is when dyspareunia occurs not at the start of the coitus or when there is insertion, but fairly deep in the pelvis. So at each thrusting, if you were to imagine that it is actually hitting the ovary, so that for that person, intercourse would be like somebody were to squeeze your balls every time that you had intercourse, that there would be that type of pain. So that's how that would have caused. So when we lifted this out, we could see clearly that it was adhered here, and that's classic of endometriosis. So various types of endometriosis. Here one can see that endometriosis of various types. This is looks like a vesicle, yeah, very clear. And that again is endometriosis. Here, the orange type of vesicle is endometriosis. These are present, and it's not infiltrating in, it's just above, and they can, at surgery, it's easily amenable to surgery. They can actually strip them out. However, the other type of endometriosis, where this is deeply infiltrating here and causing endometrial nodules, and if, as you can imagine, if one were to do a vaginal examination, and this is the pouch of Douglas, when you place the finger in the posterior fornix, you could actually feel this nodule as a very tender nodule in pouch of Douglas. So that's where the examination finding of tender nodules in pouch of Douglas, as well as you can see, this is the uterosacral ligament on that side, and the uterosacral ligament is involved and shortened, and has restricted the mobility of the uterus here. So that again can be felt when you do the vaginal examination. So when you do a vaginal examination, if you feel tethered uterus, if the uterus is not mobile, and you can actually, if there are large endometriomas, now this ovary and the endometrial tissue was actually hiding a small endometrioma here, which we found later on when we started dissecting. You can feel the adnexal fullnesses. You can feel this uterosacral feathering. You can feel the deep endometriosis, which find as nodules. You can feel them as tender nodules, and obliteration of the pouch of Douglas would result not long after if you were to leave this alone. So that's another type of endometriosis. So endometriosis can be visually seen, but cannot be completely reliably diagnosed. And here, one has started to resect out the peritoneum, to stripping out the peritoneum to take that endometriosis out. And here one can see a lot of adhesions in the ovaries. Here the ovary is adhered, and the uterosacral ligament here is completely involved and would have caused her a lot of pain because at there the nerve supply is there, and any expansion inside that restricted space with each passing menstrual cycle, the menstruation would occur and go out, but each time it bleeds into this ligament, she would have been in terrible pain. So pain is a key feature in endometriosis. Now, how do we treat endometriosis? There's no clinically or scientifically completely proven one single way of dealing with endometriosis. Clinical trials have been done. There's loads of evidence behind whatever we offer. However, there's no one single effective best way in dealing with endometriosis. So when you're dealing with endometriosis, you're actually trying to titrate your armament, your weapons, and use them to see what exactly is best for the patient in front of you. So so it depends on how one treats. So basically, when we diagnose endometriosis, we have two ways of treating that endometriosis. One is to treat it medically. The other is to treat it surgically. Now, for medical treatment, now for first-line therapy, medical treatment is first line because endometriosis surgery is fairly invasive usually. And for pain, medical therapy is the first line treatment, not surgery. And if after surgery, if you want to treat recurrent symptoms and to prevent recurrences following surgery, you can have medical therapy. When you treat when you use medical therapy, however, medical therapy does not improve endometriosis-related infertility. So if the main problem is infertility and the patient is having endometriosis, first-line therapy is going to be surgery rather than medical. Now, how does one get endometriosis? There are various hypotheses generated. One of the commonly cited hypotheses is that with menstruation, there's a retrograde blood flow, not only to the outside through the vagina, but through the fallopian tubes. It can go into the peritoneal cavity, and those endometrial cells get implanted and cause endometriosis. And there's another theory where people have speculated, because endometriosis has actually been reported in various other places than endometrial cavity, and you can't really explain how one would get endometriosis in the eye by saying that it is actually resulting from the spill of the retrograde menstruation. People have speculated that endometriosis actually is arising from pluripotent stem cells and differentiating due to abnormal stimulus differentiating into endometrial tissue in a place where it shouldn't happen. So technically, there are multiple pathophysiological theories, and currently there is no one single theory to explain how one gets endometriosis. Because we don't know exact pathophysiology, we cannot completely eradicate by removing the cause. Therefore, treatment is empirical, and there are no medications specifically developed for endometriosis with phase 1 to 4 trials passing and getting approval for treatment of endometriosis. So now this is something that they advise for patients to say that endometriosis has no specific treatment to cure once you diagnose it. And actually, it can be difficult to treat. So therefore, the aim of a treatment is to make sure that you are symptom-free and you can live your day-to-day life without endometriosis restricting anything. That includes fertility. So the treatment will be to relieve pain, slow the growth of endometriosis, improve fertility, and prevent the disease from coming back. So how do we treat endometriosis? There are many options, but what one needs to remember is that all these options do have efficacy-wise seems to be equal. So whether you use GnRH analogs with very expensive injections, dipomethylprogesterone with significant side effects like bloating, weight gain, etc., menstrual irregularities, etc., etc., oral contraception pill to treat, all these have equal efficacy demonstrated in clinical trials. So it's a matter of selecting which is best for your patient, depending on the side effect profiles and the cost. Like I said before, medical treatment is not very useful in treating infertility. Now, for pain, endometriosis-related pain, NSAID seems to be the first-line treatment. And it is safe to take NSAIDs if you're planning conception. However, for most people, or at least a significant percentage of people, NSAID alone, if they have endometriosis-related pain, will not completely take away the pain, and you will need additional treatment to relieve their pain. And there is no there's no specific NSAID that is supposed to be the best among others. So you can use, and the commonest treatment used in our setup in Sri Lanka is mefenamic acid. That doesn't mean that any other NSAID will give you the same efficacy in treating the pain. Oral contraception pill given for endometriosis is probably the most commonly prescribed, and you would realize that this is not suitable if the woman is planning to get a pregnancy. There are various methods that has been given to use continuous oral contraception pill where only the active pills are used, thereby preventing the woman from having a menstruation, or to have cyclical oral contraception pill preventing menstruation but having regular breakthrough bleeding. There's small amount of evidence to suggest that continuous administration for a long time may be more effective than cyclical management. Initially, because it is actually giving you both estrogen and progesterone, oral contraception pill may initially worsen the symptoms, but prolonged administration, like a pregnancy, how do we know that for preventing menstruation works, is that people have realized that if the woman with endometriosis gets pregnant, she would not be having periods for a long time, obvious reasons, and well, pregnancy and breastfeeding time, she will not be having periods. And when we go back and see, endometriosis have residualized and atrophied for a good degree. So pregnancy itself may be therapeutic for endometriosis. Likewise, what we're planning in most medical treatments is to mimic a pregnancy where she does not have regular menstrual cycles. Similarly, endometriotic tissue atrophies at menopause. So when we use GnRH analogs or danazole, the key aim is to make sure that to have an artificial menopause so that the woman does not menstruate, leading to atrophy of the ectopic endometrial tissue as well. So when we compare oral contraception pill to GnRH analogs, which needs to be given with injections, it seems that it is as effective in suppressing endometriosis, and with oral contraception pill, one can use it for a longer time and has much better adverse effect profile than GnRH analogs. So there are other treatments available. Progesterones given continuously is another treatment. Medroxyprogesterone acetate is oral, given orally, available but not commonly used in Sri Lanka. What we use commonly here is the depot medroxyprogesterone acetate, or DMPA, and the treatment dose seems to be 150 milligrams every 3 months. Because there's no clear evidence which doses to use, one can see it being used every month with various protocols. However, when we look at evidence base, it seems that if you were to suppress endometriosis with progesterones, not even 150 is needed. Where US there's a lower dose of 104 is available, they have proved that it is as effective as GnRH analog with less side effects. So if one is using Depo-Provera, remember that if you're using it monthly, you're doing it probably giving too much Depo-Provera, because none of these medical treatments will completely take away endometriosis 100% of the time in all women. So there are women who will respond to medical treatment, and there will be women who will not. So increasing the dose will just increase your side effect profile without giving you additional benefit in treating endometriosis. There are other progesterones that one can use, or has been used in various places, because in our setup, dipomedroxyprogesterone is the commonest used. Now, danazole is a medication that was used for endometriosis long time before everything else came up. At a dose of 200 to 800 milligrams per day. It is effective. However, it can generate lots of side effects, including permanent changes of the voice, permanent voice changes, which is not acceptable to many women. Therefore, danazole is a second-line drug because of its side effect profile rather than effectiveness. GnRH injections is also, you would see if you're seen at ward 39, we use it commonly with injections. At least sometimes, most common indication is to suppress endometriosis before you approach surgery or immediately after surgery. What it does is it creates a medical menopause, and it actually gives you, because the action is fairly quick, it gives rapid effects in managing pain. And it certainly, although it's more costlier in treatment, has a broad treatment option. Nobody has proven that it is actually superior to other medications, and you can't really continue GnRH analogs for a long time without getting problems associated with menopause, and side effect profile is significant. Now, levonorgestrel intrauterine system, or Mirena, is also effective in controlling pain related to endometriosis. And that's available, cheap, with much less side effect profile than most of the other issues, other drugs. Therefore, that has come as a first-line treatment, and especially where you want to suppress for a long time, especially after surgery, because oral contraception pill may be needed to be taken orally every day. Women might prefer the ease of use of LNGIUS. For this indication, it needs to be replaced every 3 years, and not the 5 years as per as when we use it for contraception. Jadel and Implanon, there's small amount of evidence that if you, as we realize that it actually limits the flow of the endometrial flow, there's some evidence that it might be actually beneficial, but it's not certainly a first-line treatment because there are other treatment options one can explore before using subdermal implants for pure treatment of endometriosis. Now, should one suppress endometriosis before surgery or even after surgery? There is no clear evidence to suggest what is best to do. However, most surgeons these days, once they have excised endometriosis surgically, will advise the woman either to get pregnant, which means that there will be no menstruation or hormonal, there will be hormonal suppression, or unless if you're not planning a pregnancy, to suppress with long-term hormone treatment. So there are a few small studies that have been done in pre-surgical treatment and post-surgical medical management. These are clearly used, and however, little bit more needs to be done on the evidence-based side if one wants. There are lots of evidence clinical trials going on finding a course, finding a best medical treatment. However, it's unlikely that there will be a very effective medication coming up in the near future. Now, what do we think about surgical management? Surgical management can be first line also, or especially in if the endometriosis is confined to a large endometrioma. In that case, surgical management would probably be the best. It is also it can also be used when you fail with medical management to cure or give adequate relief from her symptoms. And surgical management, there are various ways of managing it surgically. Currently favored is to clear all visible endometriotic patches and deep endometriotic patches. That's fairly invasive if the endometriosis is widespread. Traditional treatment was to remove the uterus and the ovaries, including any visible endometriotic patches that one was one was seen. So again, to reiterate, when we treat endometriosis, we can't offer a cure at the moment. The aim is to relieve symptoms and can be done with surgery or medicine. Now there is this concept that is coming that if one was to have endometriosis, it might actually mean you will have lifelong suppression with surgery, without surgery, unless one is planning a pregnancy. Again, these are favored, but clear evidence has not been demonstrated yet. Okay, so that covers what we wanted to talk about endometriosis. Okay, are we having any questions at this stage? You want to stop and ask questions?